adrenal cortex hormones, orbital diseases, and paranasal sinus diseases. They encompass all the different things that you see in terms of all the different forms of steroids, all the different orbital complications, and all the different types of sinusitis. And then that was our search from adrenal cortex hormones and orbital diseases or paranasal sinus diseases, which yielded 4,180 results, which were painstakingly combed through, of which 2 articles only fit the criteria, which is nicely elucidated in the Prisma flow sheet, which you use here. So two papers. We used nice data extraction, both I and Dr. Kaplowitz, which we have some results here, but just from basically table 1. One was from India, one was from USA. Interestingly, there's 0 articles about this in the ENT literature. Both of the articles that I found were in the ophthalmology literature. So one was a prospective, one was a retrospective. Ends were pretty small, 21 and 23. They both had 2 different groups of those that received oral. Both had received steroids and did not receive steroids. One was obviously targeting mainly pediatric patients, but then the other big one was also looking at adults as well. The first group, the first paper talked about patients that had their own protocol. So the treatment protocol was IV antibiotics, vancomycin, depending on the age, as well as ceftriaxone. And subsequently, those that did well or improved were started on steroids and oral steroid taper, essentially. And the other group did not really discuss at all what their initial medical management was, aside from that it was IV antibiotics, and they said they gave steroids. They didn't say what type or what the class of it or how much they were giving it all. And in terms of looking at surgical outcomes, they did explain how they did have to take some patients that had in both groups for surgery, but we don't know the type of surgery that was done in the first paper. And in the second one, they all had orbitotomies only, probably because it was an alpha paper. Differences groups, and again, paper from the U.S. Maybe they talk about trend towards decreased hospital stay with people that got steroids, or trend towards decreased surgery in that group, but nothing statistically significant. No side effects were reported. And in the paper from India, Dr. Pushkar, there was a statistically significant decrease in hospital stay in those patients that did receive steroids, but otherwise did not impact surgery, and they did not report any side effects from steroid use. To sort of add a little bit to the information that we got, since there was such little data, we created a survey which was planned to be sent out to the members of the American Rhinologic Society, as well as ASPO, and a group of oculoplastics physicians here in New York. Can you see these? Yeah, so there were basically 8 questions. Most of them were multiple choice, but then we had a few open-ended answers as well. So far, this was sent out to the ARS and to the oculoplastic surgeons. So I was going to go over the results quickly so you guys can get an idea what's happening. So we did get a nice 100 responses so far, which is not bad. Also makes for nice statistics. So mean age of completing your residency was 1997, median 1999, low 2006. Did you complete a fellowship? It was about 50-50. What I did learn is that you don't need to be fellowship trained in rhinology or anything to be a member of some of these societies. But I guess mainly their focus is mainly in sinus disease, and also specifically for the fellowship completion, some of them say no because they weren't available at the time. So there were no fellowships when they trained. In terms of a majority of them obviously were rhinology fellowships, some pediatric ENTs, even though they're members of the ARS. And in terms of those were the oculoplastic surgeons or people who fit into the criteria that are members of the society but did not complete a fellowship. So how often do you prescribe systemic steroids when treating children under the age of 12 with orbital complications of acute sinusitis? You can see that basically a lot of people always give it, no matter what. And then when you get to the open-ended questions, you'll see a little bit more. Very few people never give it, and there are some sort of intermediate, or depending on how frequently. So a majority of people do give it, or some people said not applicable because they say they don't treat children. And then how do you prescribe systemic steroids when treating adults with orbital complications of acute sinusitis? Basically, the numbers don't change at all because a lot of the people, as we'll see, do not use different criteria for one or the other. So about the same number. Majority do give it all the time. What do you believe is the level of evidence in the literature to support this practice? So I guess they were right in saying that lower quality evidence in terms of expert opinion or quantitative studies or case controls, and sort of the higher level studies that we look at, there's basically nothing on there as well. And in terms of question 7, so this was like one of the open-ended questions, so the numbers don't necessarily add up to 100, but it's because multiple people gave multiple answers, so I had to sort of pull them out and kind of put them into main groups. So some people said, or 25, well, basically almost 25 respondents gave that they always give it. If the person's immunocompetent, they don't have diabetes, they're not elderly or sickly, they always give it no matter what. Overwhelmingly, most people use physical examination as the way to determine whether someone received them or not, and I'll break that down. Less use radiographic findings, but that was sort of the second largest group. Some people say they gave them perioperatively before or after any sort of planned surgery, but there had to be surgery involved. Some people say that they gave a trial of antibiotics, and if there was no improvement, they would give steroids. Some never give it at all. Some of them said, I let the ophthalmologist decide, and some of them said based on the severity without sort of giving any explanation as to what that meant. When you break down the physical findings group, mainly they say there's visual change or actual or impending after ophthalmologic exam. That would be their main indication. That was the overwhelming answer for all these people, as well as orbital edema. Extraocular muscle limitation, nasal edema, and pain were less cited as different reasons as to why to give it. In terms of radiographic findings, if there's any evidence of orbital cellulitis, that was like the #1 reason, which I assume can be extrapolated that if you have an orbital abscess, at that point that they may give it as well. But if if they also commented if there was abscess formation, they'd be less likely to give it and take the patient immediately to the OR. So did their indications for using steroids differ when they looked at children versus adults? Basically, all of them said no. The ones that say yes are sort of lead to more likely to operate on adults. Overwhelmingly, they're more cautious. So I guess if they're less likely, it's going to be because they're more likely to be cautious in children. These are lower dose in children. And those are the, although the number was fine, so I got 10 people. So in terms of the literature review, there was no data in the ENT literature. Small cohorts were in the studies that we found. There was no standardization on the route or the type of steroid administered. Difference, or the only statistical difference was found in one paper, and only one thing, which is basically in the number of total hospitalization days, was decreasing the patients that got steroids, but did not change the need for surgery, and there were no adverse outcomes reported. Just to quickly review the survey results, 50% responded to give steroids always or frequently in children, 48% in adults. 16% of respondents never or rarely gave steroids in children, which was the same as basically the number in the adults. Physical exam findings were the main indications to give steroids more than radiographic or anything else, with vision change, actual or impending, or edema being the main reasons why. And the majority of respondents do not have different indications for children versus adults, which is pretty interesting. In terms of the survey, we're still waiting to navigate the treacherous waters of the ASPO approval processes to their highly guarded members, write like a thesis for them. But so we're going to send this to the ASPO members and so add their results to this in the future. So preliminary conclusions is still frequently prescribed medication in this situation. As you can see from the survey results, there's clearly a paucity of data. No ENT literature addressing the issue. So obviously more high quality studies are recommended moving forward, especially given how prevalent the use of steroids are in treating these conditions. So thank you to Dr. Bork and Dr. Rosenfeld and Dr. Kaplowitz who helped with the review, and any questions?
Any questions? All right. Our next presenter is Dr. Thakar, and her talk is development of a rat model for persistent vocal fold paralysis due to recurrent laryngeal nerve crush.
Thanks, Dr. Butts. Today I'm going to speak about some work that started with one of our chief residents, Dr. Moore, and Scott and I completed with Dr. Colmar. So we know that crush injuries of the peripheral nervous system are very well studied in the literature, but there hasn't been a good technique for a reproducible model for the recurrent laryngeal nerve. And so this was kind of the impetus for our study. Crush injuries of the peripheral nerves typically lead to axonotmesis, and we know that both patients and animals recover well after these types of injuries. The favorable outcome has been attributed to both precise axonal reinnervation of the original peripheral targets. So this slide just demonstrates the Sutherland classification of nerve injury. So neuropraxia is a mild injury, that's grade 1 if only the myelin is injured. And axonotmesis is what we're interested in, and that's if both the myelin and the axon is damaged as well. And here you see an image of that, and once again, we're looking at axonotmesis in our rats. So our aims in the study were to determine whether axonotmesis can be reliably reproduced in the rat model, and we used a target of 4 weeks for crush injury. And we also wanted to describe a detailed surgical procedure that could be replicated for further studies in the rat. Our study was approved by the SUNY Downstate Animal Care and Use Committee, and we used 10-week-old Sprague Jolly rats, which were randomly assigned to either sham, crush treatment with various instruments. So I'll just quickly describe our procedure. The first step was anesthesia. We had isoflurane